Okay, hello and welcome. My name is Joseph Caramelli. I oversee grand rounds for our Department of Psychiatry and Behavioral Sciences. And I wanted to mention just a couple of things before I turn it over to Dr. Unitzer. One is that our presentations are archived on our grand rounds website. You can always check out our prior presentations if you missed part of one or if you missed a week to look at past presentations in our series. Our series has funding from the Ripley Fund and from institutes and centers in our department, such as the Garvey Institute for Brain Health Solutions. Please complete this Grand Round speaker evaluation at the end of the presentation today. And you can always send comments or feedback on the series to me directly. And I'll stop there and turn it over to Dr. Unitzer.
All right, good afternoon, everybody. Jürgen Unitzer here, I chair the department, and today I have the pleasure and the special honor to introduce our Grand Round speaker, and I'm doing that because today's speaker is Joe Caramelli. So I'm going to say a couple things. First of all, we're getting to the end of another stubborn pandemic year, and this has not deterred us from having a fabulous Grand Round series this year. And I want to say thanks to Joe and to Semhar and to Mike who have supported this. I want to thanks to all of you who have participated and joined and given feedback. I actually think we've had some of the best Grand Rounds presentations this year that I've heard, and they're all archived. So if you missed something, you can watch it again. So today we're going to hear from Dr. Joe Caramelli, who is one of our own faculty here in psychiatry. And Joe is going to talk about his work, which examines the presentation and the care of people with bipolar disorder in the primary care setting. Primary care is often the place where we first get the opportunity to identify somebody who's struggling with a mental health disorder, including bipolar disorder. For many patients, it's also the place where they get much of their care, in some cases, all of their care. There are very few people who are true experts in the care of bipolar patients in primary care. And Joe is one of those people, I think one of a handful in the United States now. And he's doing some really impressive work in this area, and I look forward to hearing from him. And with that, I want to thank again Joe, not just for his presentation today, but for a whole year's worth of really great Grand Rounds, and welcome.
Thank you, Jürgen. Well, I'll share my presentation slides now. Okay. Well, today I'll present a presentation titled Bipolar Disorder in Primary Care, Research and Clinical Updates. And I'll mention I started working on, in the department and started working in this area on bipolar disorder in primary care as a fellow during doing a research fellowship in primary care psychiatry that at the time was directed by Dr. Wayne Caton. And that fellowship ended in 2014, and since then I've stayed on as a faculty member. So I want to walk through 5 different areas of research related to bipolar disorder in primary care. Cover a couple of studies, maybe in each domain, synthesize things, and just describe the work that I've gone through, including background in clinical epidemiology, clinical characteristics, clinician experiences, results of a large clinical trial that many of us here worked on, and describe a new measure and potential next steps in this area. So first is about the background in clinical epidemiology. And I think it brings up a question about why bipolar disorder in primary care. Why would we focus on this area? Isn't bipolar disorder considered maybe a specialty problem? And I think there's a straightforward answer to this question, which is that most patients with bipolar disorder receive treatment in primary care. And that may be for the long term, but it might also be that patients kind of move back and forth, receiving an episode of care in a specialty setting, returning to a primary care setting for continued care, maybe electing to stop specialty treatment for some period, representing the primary care. At some point, if you follow people long enough, most patients with bipolar disorder receive treatment in primary care. There's potential areas of concern that come up with this. And this is not as, these are not points of criticism of our colleagues in primary care. It's more of points about how might psychiatrists and psychologists, how might we be helpful? How might we try to improve quality of care in primary care? But in general, when care is delivered in primary care, there's lower quality of care delivered for individuals with bipolar disorder. Sometimes PCPs, this is reported in one study, see patients with bipolar disorder as complicated or complex. There are worse outcomes. There's also problems of limited psychiatrist availability and problems with referral directly to psychiatrists. I want to talk a little about the clinical epidemiology that goes along with this statement about most patients receiving care in primary care. And I think there's two ways to think through the clinical epidemiology. One is just a straightforward way about disorder prevalence. Excuse me. If we look at prevalence of bipolar disorder in primary care, one just summary statement about this would be that the prevalence is estimated as twice the prevalence as the general population prevalence of bipolar disorder. Another way to think about it too is just, as I mentioned before, where people are presenting for care. And interestingly, over a 15-year period from 1995 to 2010, the percentage of clinical visits anywhere in any clinical setting that resulted in a bipolar disorder diagnosis increased most rapidly in primary care and more rapidly in primary care compared to specialty mental health care settings. So two different ways to consider this. And I'll give you sort of a summary point here about prevalence studies that we had worked on before. One is looking at prevalence of bipolar disorder in general primary care samples. This was a systematic review that I had developed and worked on with the group during the fellowship. And we synthesized studies that were in the literature and found that the statement that I had mentioned in the prior slide, that it looked like estimated prevalence was approximately twice the prevalence in primary care compared to general population. And a couple of years later, these results were quantitatively synthesized in a meta-analysis that estimated a prevalence of approximately 3.7%. And this was specifically for bipolar 1 and bipolar 2 disorder, which is, if you think about 1% prevalence in the general population for each of those disorders, it's about twice the prevalence. Excuse me. There may be an occasion when I mute and take a break to cough a few times. I had been sick previously. I've got some fluids to drink here, so if I mute, that's why. The other thing we had looked at was prevalence of bipolar disorder in people presenting with depression complaints. Now, among individuals presenting with depression, it would be more likely to expect an elevated prevalence of bipolar disorder. And we had found across approximately 7 studies or so an estimated prevalence of 10%. And interestingly, these results were also replicated and looked at in the meta-analysis as well, where there was estimated prevalence of 14% with a confidence interval of 8 to 20. Okay. Excuse me. The other way to think about this, as mentioned, was where people present for care. And if you look just in the middle here, under general medical, you see in the light blue here, similar proportions of individuals with bipolar 2 disorder and bipolar 1, if added together, present for care in primary care settings here in the middle, as in specialty care settings over on the left in the dark blue. So similar proportions of individuals seeking treatment from psychiatrists as in primary care settings. There's also a high proportion of individuals receiving no treatment in the preceding 12 months. But again, in primary care settings, similar proportion as those seeking treatment in specialty mental health care settings. There's also been interesting, some interesting findings related to medication treatment trends that I'd like to make a comparison about psychiatrists and primary care clinicians. These studies were published last year. If you look at the figure on the left with psychiatrists, in the red line, you see a decreasing percentage of individuals with bipolar disorder prescribed treatment with mood stabilizer medication, decreasing around 2005, 2006, and staying about 30%. You see an increase in the blue line in second generation antipsychotics, increasing about 15 years ago, and then maintaining about above half of people. And you see a decrease in lithium from 30% down to about 1/5 of patients over the last years of that data set. And what's interesting about this is when in a report that came out in a different journal, there's almost an identical trend in a primary care setting. It's very interesting. An increase in second generation antipsychotics, decrease in other types of mood stabilizers, and decrease in lithium. A decrease to a lower proportion than is in specialty care settings, but similar types of medication prescription trends in the two settings. Now it's reporting observational data, but it's interesting to see these trends. So the next thing I want to move on to is talking about clinical characteristics of individuals with bipolar disorder in primary care settings. And one of the things that I think was consistent with my own clinical experience was that in research studies, we found that the clinical characteristics of people in primary care settings seem to be very similar to patients who are presenting in specialty care settings. And part of that explanation, I think, is just what I was saying earlier, that patients are, there's not a distinct group of patients who are primary care patients and a distinct group of specialty care patients. It seems like it's a lot of patients are moving back and forth between settings for whatever reason. And I'll describe these characteristics, one in the clinical epidemiological study and the other that comes from a clinical trial. So this was a study I worked on as a fellow as well, where we looked at the clinical characteristics of over 700 patients presenting for care for bipolar disorder in primary care settings from federally qualified health centers in Washington state. And in summary, in this observational study, we found that patients demonstrated high symptom severity and high levels of psychosocial impairment. And there's a couple of specific points about this that I walk through here. One is that there is, again, this high burden of depressive symptoms measured by the PHQ-9 with a mean score of 18. And notably, almost 2/3 of people reported a score of 1 or more on item 9 of the PHQ-9, which is a measure of thoughts about being better off dead or suicidal thoughts. So high symptom severity. The other thing is that the majority of patients in this sample had passed specialty mental health care. Sort of demonstrating that point about patients moving between settings. And 1/3 had prior psychiatric hospitalization. And at this time, patients were presenting in primary care settings for treatment. 15% at the time reported experiencing current homelessness. 1/4 of people reported lack of a current support person, and about 1/3 lack of dependable transportation. Over the course of treatment in a primary care setting, about 30% of people had experienced significant reduction in depression, defined as a PHQ-9 score of less than 10. So that's about 70% of people not experiencing that improvement. So out of that 70%, only about 1/4 of patients were actually referred from primary care to specialty care. So high symptom severity, high psychosocial impairment, sort of a modest degree of significant reduction in depression, and not a lot of people being referred out to specialty care. There aren't explanations for the low referral rates or the sort of lower proportion of significant reduction in depression, given it's an observational data study, but interesting. Baseline characteristics from a large trial. This is a trial I'll talk about later in the presentation as well, with demographic characteristics on the left and clinical characteristics on the right. This is 179 individuals in primary care diagnosed with bipolar disorder by a psychiatrist reporting high degree of depression measured with the SCL-20, concurrent manic symptoms measured with the Altman Mania Rating Scale with a mean of about 10. And then with classification of current mood state with the internal state scale, which is used to classify 4 different mood states. I think it's interesting, about a quarter of people were classified as current manic or hypomanic mood state, then about a third each of sort of a mixed state or depression, with just over 10% being classified as current euthymia, based on this internal state scale. And in this sample, almost everyone had passed specialty mental health care, 94%. And at this point in this group, they were seeking treatment in primary care, and not for just continuing maintenance treatment. I mean, as you can see from the mood state classification, about 90% of people were classified as in a current mood episode. So there were a couple of studies that I worked on related to what's it like for clinicians in primary care to evaluate, treat patients with bipolar disorder. What are the clinical experiences of caring for individuals with bipolar disorder? And there's 3 different studies that I'll mention about this. One that evaluated the experience of psychiatrists and psychologists working in collaborative care and in telehealth care. One that evaluated the experience of primary care clinicians. And then another, a small data set about patient experience about receiving treatment in primary care settings. So in this study, we had, it's an interesting study. I had taken, I'll point out Dr. Clarence Spigner here as a co-author on this paper. Dr. Spigner was teaching a course in the School of Public Health on qualitative research methods, and I was in public health school at the time when I took the course. And so this was kind of a course project that turned into a scholarly project while I was learning the methods in the course. And what we did here was sampled from a group of psychiatrists, mostly working here at UW, but some working other places in Washington State, who were working as psychiatric consultants in collaborative care, in primary care clinics throughout Washington. And we said, well, many of the psychiatrists had done this work for months to years, and they were starting to observe patients with bipolar disorder in their collaborative care treatment programs, and they were wondering what to do about that. So I had worked on this study to understand what they were doing, what kinds of treatment they were doing, what was their assessment, and I had interviewed them and then transcribed the data, did qualitative analyses, and found 3 themes in the data. One theme that came out, which was interesting, was the importance of working as a team, working as a collaborative care team to evaluate and treat individuals with bipolar disorder in primary care. And one point that one psychiatrist said was, so I spend a lot of time educating care managers on how to take a mood history to look for periods of shifts in mood and energy, getting at the point of adding structure to assessment, seeing this as a team assessment in collaborative care. The other thing that came out of this study, from a group of psychiatrists doing collaborative care, was that they actually had found strengths of collaborative care working in a primary care setting for treating individuals with bipolar disorder. And a couple of representative quotes from that were, well, we often get more frequent assessments in primary care because we have data from PCP visit, from care manager visit. Care manager can see people more frequently than I typically would. The other thing was that psychiatrists in this study mentioned kind of describing bipolar disorder as a provisional diagnosis, being okay with that, tolerating some uncertainty, deciding to do prospective assessment to inform or refine diagnosis, giving clear guidelines to the collaborative care team about how to gather this additional information, monitor the patient, and to follow closely. The third theme that came out of this study was that the psychiatrists had found ways, or found a need, to adapt their specialty skills to a primary care setting, such as instead of just giving a medication recommendation, giving maybe dosing recommendations, monitoring for adverse effects, and so on. And then interestingly, I think to me, is that the psychiatrists who were doing this kind of work, I think started to have the experience that a lot of PCPs or primary care clinicians have, with trying to refer a patient out of primary care to specialty care. In these circumstances, sometimes patients wouldn't improve in collaborative care, and the psychiatrist would recommend, let's get this patient into direct specialty care in a mental health clinic. And sometimes that wouldn't work out. And there was this quote that came out saying, yeah, I say the most common thing is that until somebody gets sick enough, it's actually pretty hard to refer the patient, especially mental health. So have kind of experiencing what PCPs experience at times. Well, sorry about the coughing interruptions. I actually feel fine. It's just this cough is sticking around. I'll move on to the next study here. So this idea about surprise benefits of collaborative care or primary care treatment for individuals with bipolar disorder came out in another study that I had worked on, another report that I worked on with Dr. John Kern. Now, Dr. Kern had worked on developing a partnership between a federally qualified health center and a community mental health center, where the psychiatrist would provide collaborative care with a team in the FQHC. And in this study, over the course of 8 years, 920 patients with bipolar disorder were treated in a primary care setting, and only about 28% were referred to a community mental health center from the primary care clinic. So the majority of patients were treated in primary care, and the PCPs and the psychiatrists actually found out that it went pretty well at times. The primary care clinicians had commented, well, we were doing this on our own before, and now we have a psychiatrist here to sort of help out, give guidance on assessment, help us refine diagnosis, and give treatment recommendations. And with this collaboration, they were able to treat really a high number of patients over years. One other study related to clinician experience was about assessing in more detail the experience of primary care clinicians. And in this study, we had interviewed 9 primary care clinicians and 6 patients with a little bit to understand what it was like to either diagnose or treat bipolar disorder in primary care, or what it was like for patients to be assessed for bipolar disorder or to receive treatment in a primary care setting. And in this study, 3 themes came out of these interviews. One was the theme of bipolar disorder detection. And I think a couple of representative quotes from this study, which illustrate ways that we as specialists might try to improve detection, or we might try to be helpful in detecting bipolar disorder. So the PHQ-9 is just for depression, not for bipolar disorder, consistent with theme 1. Or I see a lot of depression and sometimes miss bipolar disorder, but I'm comfortable treating depression. The second theme that came out was related to referral of specialty mental health. You know, it's hard to get in the mental health clinic, and I don't really hear from them, maybe once a year. It's kind of a couple of challenges in one quote, challenges about referral, and then just about communication in general with colleagues in the mental health clinic. Theme 3 about medication treatment from a primary care clinician. I prescribe treatment with a little bit of quetiapine, not a lot, and that's about it. Or a lot of times we just need some guidance. And I think both of these quotes give potential examples for ways that psychiatrists could be helpful in primary care settings, either with guiding ways to intensify treatment, guiding a couple of potential next steps in treatment, and so on. And then one quote from a patient here as well. And there weren't as many patients in this study, so I saw it kind of more as preliminary data, but the care manager helped me understand why citalopram or whatever it is wasn't helping me. So kind of reflecting themes 1 and 3 about detection, maybe not initially detecting bipolar disorder, later detecting it in the context of collaborative care, and then related to medication treatment. Now, the final sort of clinician experience qualitative study that I'll talk about right now was one that came out of a clinical trial that I'll talk about in a little bit. It's a very recent study, and I do want to highlight that this study was led by Dr. Molly Howland, who's our current psychiatry resident here at UW. This was an interesting project. I think this was a very good example of a project that met the needs of a clinical trial, that helped the investigators understand more about what it was like to deliver the clinical interventions that were tested in this trial, and was consistent with the interests and priorities of Dr. Howland, who was interested in outpatient CL psychiatry and was interested in understanding how clinicians learn new clinical services and how to deliver them in a new setting. So in this study, we had collected additional data and interviewed 14 clinicians, 10 psychiatrists and 4 psychologists, who were either doing telehealth care directly to patients in primary care, patients with bipolar disorder and or PTSD. They were either doing direct care in primary care or doing collaborative care. And it's interesting. A couple of different themes came out of this data as well. Generally, the clinicians saw this as a sort of positive work. They saw it as fulfilling. They felt like they were meeting needs in places that they wouldn't typically see patients in, but there were some challenges like communication barriers with talking with several or many different PCPs, some EMR challenges and credentialing barriers. So generally kind of rewarding, motivating work, but some sort of practical challenges that are addressable. And I'll talk now about that clinical trial that I had mentioned just in the prior slide. This is kind of moving into the next phase here about testing a treatment trial called the SPIRIT study, which was a large pragmatic effectiveness trial that took place in 3 states. And SPIRIT stood for the Study to Promote Innovation in Rural Integrated Telepsychiatry. And the study period was 4 years long. It just ended in 2020. And I want to go through four different aspects of this trial. One is just some background about it. 2 is a study that we did in the context of this trial related to assessment and diagnosis. 3, to describe the primary results of the trial. And 4, to talk over a new symptom measure, actually, that was developed in the context of this trial, and some preliminary data about that symptom measure. Okay, so one background slide on the SPIRIT trial. So in short, this trial recruited 1,004 patients, or enrolled 1,004 patients rather, and for individuals in primary care settings who were screening positive for bipolar disorder and or post-traumatic stress disorder. And patients in this trial were randomized to treatment, so in one of 2 ways. It was an effectiveness study, so both arms were treatment arms. Patients were either treated directly by psychiatrists and psychologists through telehealth in the primary care setting, so direct care, illustrated here by the top of the pyramid, number 5, referral to mental health specialty care, or patients were randomized to treatment with collaborative care, team-based treatment, systematic treatment to target using a registry, population-based approach with a care manager, collaborative care treatment in the primary care setting. So I'll make a point about each of these 2 arms. One is that colleague Dr. Amy Bauer here at UW led the collaborative care arm, oversaw training and implementation, and led that arm. And the referral arm initially was led by Dr. Richard Veith. And about a couple of years into the trial, as Dr. Veith FTE decreased, and I had an opportunity to sort of step into this leadership role as well in this trial. This was a good learning opportunity for me, really a big opportunity. I got to learn a lot about clinical trials. I had already been directly caring for patients in this trial, seeing patients directly in primary care clinics throughout Washington. So this was a chance to learn more about the operations of a clinical trial in general. And I want to mention too, there were a lot of people that worked on this trial in 3 different states, but also just here at UW. This was a very large study. Again, I believe I've included everyone. It's possible I've left someone's name off, which I'm sorry about, but I think that's everyone. But there were a lot of people. Again, people screening positive for bipolar disorder and or PTSD randomized to one of two active treatments. So because people were enrolled based on screening only, it brought up an opportunity for us to say, well, what were the actual psychiatric diagnoses in people who were screening positive for bipolar disorder or screening positive for PTSD? So we did a secondary analysis from data collected in this trial, and I'll explain how we did this. So inclusion criteria for this clinical trial were a positive screen for either PTSD on the PCL screening instrument, or really positive screen on the CIDI measure instrument for bipolar disorder. And then patients would agree and consent and enroll, then be randomized right after the baseline survey occurred to one of two arms, and then receive 12 months of treatment. So what we did in both arms of this study, in the collaborative care arm and in the telehealth care arm, patients received psychiatrist consultation via telehealth. And that's not always a typical part of collaborative care, but for this trial, for this target population, it was concluded this was an important point to do to assess diagnosis. And we decided to look at diagnosis at this time point because it was the time point that was closest to when the screening instruments were administered, giving us a chance to see, well, what were diagnoses made by a psychiatrist relatively close to when the instruments were administered. It's possible that diagnoses evolved or changed over the course of 12 months, which is something that we're sort of considering looking at as a potential next step. And I want to mention too that for this study, we included 767 people who had this psychiatrist consultation. So what were the results? So a couple of groups of patients to think about. First is the group of people who screened positive for PTSD and screened negative for bipolar disorder. And that was most people in this trial. And probably unsurprisingly, about 2/3 of people were diagnosed with PTSD, almost 70% diagnosed with a concurrent or with a mood disorder or with depressive disorder specifically, over 40% with anxiety disorder. But still, interestingly, negative screen on this instrument, still 15% diagnosed with bipolar disorder. And then the other group was people who screened positive on both instruments, which was about 250 people. Similar proportion of diagnoses of PTSD, about 2/3. But then what's interesting is almost equal numbers of people being diagnosed with depression or with bipolar disorder. So a higher proportion compared to the negative screening group, but still not equivalent to a diagnosis of bipolar disorder. And a couple of other points about this. One is that about 15% of people were diagnosed with a substance use disorder, about 10% with personality disorder. And the other notable point is that in both groups, few people had just one psychiatric diagnosis. Most had 2 to 3 diagnoses, and about 10 to 15% had 4 or more diagnoses determined at the time of an initial consultation. Here's a figure. That's another way to consider these results, with decreasing proportions moving to the left, with the more common diagnoses at the top. It makes sense that we identified many individuals with PTSD and mood disorders. That was the intent of the trial. But I want to highlight one way to interpret this data. This is a figure that we had from the paper, and this is a different figure that wasn't included in the paper, but I think is, after I've had more time to think about the results, maybe a more useful way to think about the bipolar disorder diagnosis. Here we have at the bottom the name of the screening instrument, the CIDI, and when the screening is negative, is here, and the screening positive on the right, and major depression in blue and bipolar disorder diagnosis in orange. If the screening result was negative, or when it was negative, there was about a 4-to-1 proportion of diagnoses of major depression to bipolar disorder, about 4-to-1. And then if the when the screening result was positive, looking at the sample, the proportion was more like 1-to-1. And I think that's maybe at this point, one of the more helpful ways to think about screening for bipolar disorder, more about sort of increasing likelihood or shifting the distribution of mood disorder diagnoses in a population, rather than equating a positive screening result to diagnosis, more about perhaps increasing likelihood. And there's a related study to this. There's a similar study that I want to make a comparison to that was done by Dr. James Phelps and colleagues down in Corvallis, Oregon, in their health system. And in this study, they were treating patients with bipolar disorder in primary care using what they call a variation of collaborative care. And they assessed 641 patients in a primary care setting and used the same screening instrument, the CIDI, that we had used in the SPIRIT study. But beyond that, they also, and this is reported in the supplement of this paper, they also had a additional sort of systematic information that was collected from patients, assessing age of onset of mood disorder, number of mood episodes, how sudden the mood episodes are, any peripartum onset, response to antidepressants, any speediness or restlessness associated with antidepressants, and so on. And also different in this study, the psychiatrist didn't see the patients directly, so it was more about indirect assessment, and partly why that structured assessment was used. So, and with how they reported their results here was partly by screening results, but then also looking at the outcome of what they called impression of bipolar disorder or suspicion for bipolar disorder. So the outcome was not diagnosis. It was, is there a possible diagnosis? Is there a concern for? Is this something that should be continued to assess for? Or was it diagnosis? It was all of those things kind of together. I think there are a couple of interesting things in their table 2 here. One is that about 20% of people had a positive screen. That's interesting. So if this is administered, if you administer this instrument in a typical or similar type of primary care setting, you might expect 20% positive screen. And the other was that an even higher number, above a third, in this sample from primary care, the consulting psychiatrist thought, well, I think in about a third of circumstances, I have concern for or suspicion for or an impression, what they call a positive impression of bipolar disorder, suggesting that in some settings, prevalence can concentrate in maybe if there are fewer other options for specialty mental health care, and that continued assessment over time can really help to inform and refine that impression. But if people are practicing in a similar type of setting, it might not be, there might be up to 35% of people where a psychiatric consultant might wonder or think about bipolar disorder, especially when considering a spectrum type approach. Anyway, that was away from the SPIRIT trial for a minute. Get back to the results, primary results of the SPIRIT study, which are right here, summarized in a visual abstract from JAMA Psychiatry. You see that there were 1,004 patients randomized, about half and half to each arm of the study, and that looking here in the right box, there was significant improvements on the primary outcome of mental health functioning over the course of 12 months of treatment in both arms, and no differences between the two arms. And if you look here at one of the tables, you'll see that the primary outcome is on top. And one way to interpret this is here on the left, TCC is better, is the collaborative care arm, and TER is better is the referral arm. And for every outcome except one, which is PTSD symptoms, the confidence intervals all cross the line, showing no difference between the two arms. And the other thing to think about too is symptom trajectories. and not just the outcomes reported in the prior slide. And here you see depression scores in panel C here decreasing significantly in both arms, no difference between arms. Generalized anxiety symptoms decreasing, manic symptoms decreasing, proportion in a mood state, in a euthymic mood state increasing in both arms, and no differences between the two arms. Some interesting findings. And I'm going to have to move on. I would have liked to have maybe paused a bit more to reflect on those, but I'll move on to one other study that came out of this clinical trial, which was a new measure. So in this clinical trial, both arms of the study used what's called measurement-based care, which includes consistent measurement of current symptoms, comparing current symptoms to past symptoms, which can help to detect either clinical deterioration or lack of improvement, which can then maybe contribute or lead to a treatment change and improved outcomes. So both studies were using measurement-based care. Both arms were using measurement-based care. And here's an example of it. Here's an example from one patient that was in this trial of 1,004 patients. And this was an individual with bipolar disorder who was seen in primary care. And we could pull up these plots to look at with patients. We were using the PHQ-9 measure for depressive symptoms, which was elevated at baseline for this patient. And we were using a new measure called the PMQ-9, or the Patient Mania Questionnaire 9, to monitor manic symptoms, which decreased over time with treatment in the study. So I want to mention that in individuals with bipolar disorder, it is important to assess depressive and manic symptoms concurrently. Many individuals experience a high proportion of days with symptoms. Some studies have shown over half of days people may experience even trace symptoms. Often there's depressive symptoms or subsyndromal depressive and hypomanic symptoms. But the other thing is that even if someone's experiencing a sort of episodic bipolar depression, approximately 70% or sometimes more people will have one or more hypomanic or concurrent manic symptom. And the other thing is, after during acute treatment, any kind of persistent residual symptoms at the end of acute treatment can worsen outcomes over time. Residual symptoms are associated with decreased time or shorter time until recurrence of next mood episode. So there'd be importance in monitoring for manic symptoms and depressive symptoms during the context of acute treatment, and monitoring towards the end of acute treatment too, to pick up any residual symptoms. And how might a clinician or practice choose a measure to use? Well, it's important to consider the clinical setting, current use of measures in practice, and the bipolar disorder prevalence. And in the SPIRIT trial specifically, the settings that we were working in were already using the PHQ-9 for depressive symptoms, as a lot of primary care clinics already do. And the setting, of course, was primary care. And we expected to include people with bipolar disorder in the trial. That was part of the target population. So at least for the trial population, we were expecting somewhat elevated prevalence of bipolar disorder. So we did want to have a measure to monitor manic symptoms. However, the results of the symptom measures were going to be interpreted in one arm by, sometimes interpreted by primary care clinicians, sometimes by care managers, sometimes by psychiatric consultants in the collaborative care arm. And in the other arm, we're going to be interpreted by psychiatrists and psychologists. And we wanted to use the same measure in both arms. So we looked for something that was sort of generally okay to use in a primary care setting. And like I said, the PHQ-9 measure was already in use. So what we developed in the context of this study was a measure called the PMQ-9, Patient Mania Questionnaire 9. It has 9 items. As you can see, it's very similar to the PHQ-9. It has brief sort of item stems. It has not at all, several days, more than half a day, nearly every day, 0 to 3, just like the PHQ-9. Similar total score of 27. Cutoff, we had developed cutoffs that were similar to the PHQ-9 as well. And then we evaluated the measure in use. We did a psychometric evaluation and sort of a clinical use evaluation. And we had described these results that are just out recently in the Journal of General Internal Medicine. So I showed this slide earlier, but this is one of the samples of patients where we did the psychometric evaluation in 179 people diagnosed with bipolar disorder. But I want to mention too, for this psychometric evaluation, there were two samples. There was the sample B of people diagnosed specifically with bipolar disorder. And we looked at clinical data from the trial to do the psychometric evaluations to assess internal consistency and sensitivity to change. And in sample A, we looked at a random sample of people from the trial, which included a range of diagnoses, as I showed before, to test different psychometric properties that weren't specific to bipolar disorder, such as test-retest reliability and concurrent validity with other standardized or with other measures with psychometric validity. So I'll show you two over time using some of the clinical data from the trial. We looked at PHQ-9 and PMQ-9 scores, and we made up classifications using a score of 10 as a cutoff, and we said low depression, low mania was individuals with scores below 10 on each measure, and then high depression, high mania was individuals with scores 10 or more on both measures, and then the low depression, high mania, high depression, low mania as well. And over the course of treatment in this trial, we found that at baseline, which is the dashed line here, 5% of people with bipolar disorder were in the low depression, low mania, which is and at the final clinical observation, that was close to about a third of people. Likewise, close to 3/4 of people with high depression, high mania at baseline, and then at final clinical observation in the trial, that had decreased down to about 40%, showing sensitivity to change of the PMQ-9 along with the PHQ-9. So some initial conclusions about this new patient-reported manic symptom measure. It was widely used in a clinical trial. It wasn't required to use it, but many people used it throughout the study, throughout the years of the study. And it's helpful for monitoring manic symptoms over time. But it's not a screening instrument. It's not used to identify individuals with bipolar disorder. It doesn't assess lifetime history. It doesn't assess diagnosis, other aspects of diagnosis. It's for use, at least currently, in individuals diagnosed with bipolar disorder, where it's important to monitor manic and depressive symptoms. The last thing I'll say about this measure, and actually the final study that I'll describe, was just a brief study that I had done in response to, not in response, but as a next step of evaluating the PMQ-9 that a group of us worked on as a follow-up to the SPIRIT study, where we surveyed 109 clinicians about measures. As I started writing about use of measures in clinical care, I would often encounter a response of, well, sometimes quality of life or measures or health-related quality of life measures are preferable. And it's interesting to think about. So I wanted to see what other clinicians thought about that. So we developed a group of 8 different measures, 4 symptom measures, 4 health-related quality of life measures that have use in individuals with bipolar disorder. And we showed people 4 of the measures. They were close to randomly assigned to look at 4 out of the 8 measures. And we had about a little less than half were psychiatrists, a little over a third psychologists, some primary care clinicians, and 5 social workers in this group. Many similar proportions worked in a general mental health clinic and primary care. About a fifth worked in a hospital setting, and there were some who worked in a bipolar disorder specialty setting. And what we wanted to understand was what are clinician preferences, health-related quality of life measures, or symptom measures. And we did include the PMQ-9 combined with the PHQ-9 in this group of symptom measures. And that ended up being the top-rated or most preferred measure in this sample of clinicians. We asked people to rate each measure or measure combination from 0 to 10 on perceived helpfulness. How helpful would this information be in clinical practice and on perceived acceptability. Could you use this in your clinical practice? And the symptom measures, largely, 3 of them were higher ranked than the top-rated health-related quality of life measure. And the top-rated symptom measure was significantly higher than the top-rated quality of life measure. So at least in this preliminary study, the clinicians that we sampled had a preference for patient-reported symptom measures over patient-reported health-related quality of life measures, and specifically preferred this new measure, PMQ-9, combined with the PHQ-9 when monitoring treatment of individuals with bipolar disorder. So that's the final study. I will stop here and to go over any questions or comments that people have. Yeah, I'll stop sharing my screen here. Thank you.
Okay. Well, Joe, thank you for a really, really fine presentation. Congrats on a whole bunch of really great research, and thank you for a practical new tool, a new scale to measure the severity of manic symptoms. I think this is something many of us have a good use for, can appreciate. We do have time for a couple of questions before I make a few quick comments to sort of wrap us up. There's a great question, and Joe, I'll let you look at it yourself as well, about the fact that sometimes patients who experience mania can have a difficult time recalling or remembering the specifics of their manic episode and their experiences. What about an approach that is more like what we do with ADHD, like the Vanderbilt scales that rely on multiple informants, where you'd have yourself maybe fill out a scale, and then you'd have, somebody who's close to you, who knows you and has watched you do things, fill out a scale.
That's interesting. Yeah, I could see that being, the first thing that comes to mind is that would be especially helpful for screening instruments related to diagnosis. I hadn't thought about that as a way to be informative and helpful for monitoring treatment in people already diagnosed with bipolar disorder, like with the PMQ-9. It's making me think a little bit about more like clinician observed measures. And there are some clinician observed measures that have other observants who can comment on symptom severity. Often these are used in hospital settings, or used sometimes with instruction, can be used outside of the hospital setting. But I think that point about other informants or other ways of getting information would be especially helpful for diagnosis.
Yeah, there are other conditions. So ADHD may be a good one. Obviously, children and adolescents who might have a harder time really relating what's going on. At the other end of the life course, there are people who are experiencing dementia. So there are a couple of dementia symptom rating scales that are, that have an informant perspective also. So maybe something worth thinking about. Probably a little bit more challenging to implement, because now you need 2 people, right? But I think it's a really interesting suggestion. So we have a few minutes. If others have questions, feel free to type them into the Q&A or into the chat. What I want to say, while we're waiting to see if we have any more questions, I just want to thank again Joe for not just a great presentation today, but also for really leading a whole new way we've done our grand rounds, all online, all taped, and a lot more of it. We've been able to do it several times a month as opposed to once a month, and we've had some really fine presentations this year. So thank you to you, to the rest of the team. And of course, thanks to everybody who comes and joins us for these presentations. Joe, anything else you want to say?
Yes, there is one thing I didn't mention now that we're talking about just the grand rounds in general. I hadn't mentioned this earlier on, but intended to. Part of why I'm presenting today is that I'm going up for promotion this year, and there's a fairly large group of us going up for promotion this year, and I've invited people from that group to present in the grand round series. As a way for people to synthesize their work, describe it to the department as the department considers candidates for promotion. I thought I'd go early on to kind of show it goes okay, and I'd like to encourage people to do so. I think I've reached out to everyone But if I've overlooked someone inadvertently, please let me know, and we can try to find a day for that.
Well, thank you for mentioning that. You obviously started by setting a really fine example of what that could look like. I do agree. I think it'd be nice if those of you who are considering a promotion this year or sometime in the near future, reach out to Joe or me or any of us and say, I'd like an opportunity to share what I do. Because we have over 300 faculty in the department, and at some point this becomes relevant for everybody. And we have an approach where we have the entire faculty vote on other people's promotions, and not everybody knows what everybody is doing. So this is one really nice way to sort of present an overview of who you are, what you do in your professional work and your scholarly work to the rest of us. Okay, I don't see other questions, and I think we're almost at time. So I just hope, again, thanks to Joe for a great final presentation for the year, for a good year of Grand Rounds. I hope you all have a wonderful holiday season, that you get to celebrate whatever traditions you and your family like to celebrate. And we will, Joe and I and all of us, we will see you in the new year.
Bye, everyone.
Take care.